Hi, I'm Chao-Wei Hwang from the Johns Hopkins University School of Medicine and from the Frederick Health Hospital. Today we're going to be talking about a STEMI caused by an angiographically invisible stent edge dissection. The patient is a 60-year-old former tennis pro who has been having increasingly lifestyle-limiting angina over the past several months. His cardiologist has been up-titrating his anti-anginal medications, but despite the meds, he is no longer able to play singles tennis without angina. His echo showed a normal ejection fraction, but nuclear stress test showed mid to distal anterolateral ischemia, and he was referred for Cath. And on Cath, the RCA had only minor irregularities, and the circumflex had only mild disease. The LAD and its branches are shown here. Take a look at it. So what we see is a possibly obstructive lesion in the LAD and at the diagonal. The diagonal itself is a fairly substantial vessel with a severe mid-segment lesion. We thought that this was probably the culprit for his angina and for the anterolateral ischemia on his nuclear stress test. There was also a possible obstructive lesion at the ostium of the diagonal. So what should we do? Should we stent the LAD and diagonal and do some fancy footwork bifurcation PCI? Or should we just keep it simple and just stent the diagonal and stay away from its ostium? So here was our plan. We would FFR the LAD to see if the LAD needed to be treated at all. We would also FFR the diagonal, both distal and proximal to the mid-segment lesion, to help us decide whether the osteodiagonal lesion was hemodynamically significant. If everything is ischemic, then we would go for a bifurcation PCI. But we're hoping to keep it simple and only have to do the mid-diagonal lesion. So FFR the LAD and proximal diagonal were not significant, as it turns out. FFR only became significant when the wire was placed in the distal diagonal. So this is good news for us. All we had to do was to stent the mid-diagonal lesion and leave everything else alone. A chip shot. So we went to work. The patient got aspirin, clopidogrel, and unfractionated heparin. The diagonal wired easily with a BMW and was dilated with a 2.25 millimeter balloon, and we then deployed a 2.25 by 28 millimeter DES. After stenting, we noticed a very thin line at the proximal edge of a stent. A little hard to see on the cine, but you can see it here in the fixed image with the white arrow. This is classic for a proximal stent edge dissection. So stent edge dissections are no big deal, very common, cost of doing business. We already have a wire down, so it was easily covered with an overlapping 2.25 by 8 millimeter DES. We then sequentially post-dilated with 2.25 and 2.5 millimeter NC balloons. And here is the final angiographic result. It looks quite good. The edge dissection is gone. The ostium of the diagonal and the bifurcation are intact, and we have TIMI 3 flow everywhere. Another happy customer. The patient initially did quite well. He had an uneventful stay in the PACU and was moved to the cardiac telemetry unit. But unfortunately, about 6 hours later, the floor nurse got called because the patient was having chest pain. It turned out to be very severe, 9 out of 10, and he looked diaphoretic and quite uncomfortable. ECG showed 1 millimeter ST elevations in the V6 and 1 and about half a millimeter in AVL, and these were not present on the ECG immediately post-PCI. A rapid response team was called, and the interventional cardiologist was also alerted. The patient was given sublingual nitroglycerin, and a repeat ECG about 10 minutes later showed improved ST elevations, but it was still about half a millimeter in leads V6 and 1. His chest pain had improved somewhat by this point, but it was still 6 out of 10. So the patient was taken back to the cath lab for a relook. On relook angiography, the diagonal stent looked widely patent. However, the distal branch of the diagonal now appeared to be subtotally occluded. Was it thrombus? But it was pristine on the first cath. And a little bit more subtle, but the proximal part of the diagonal now also appears to be somewhat irregular. That segment was also pristine on the first cath. So what happened? This is all a little confusing. Was there a distal wire dissection? Is there some issue in the proximal part of the diagonal? We decided to do an OCT to take a closer look. So here's the OCT. A couple of interesting findings. First, the stent does not appear to be completely opposed to the vessel wall. So even though the angiographic appearance was quite good after post-dilation with the 2.5 millimeter NC balloon, it turns out that the diagonal branch was actually 3.0 millimeter in diameter approximately. Second, there is a dissection at the ostium of the diagonal that is extending out into the LAD. This was not angiographically apparent at all after PCI. So what probably happened was that thrombus formed either at the dissection or under the malopose stent. This resulted in transient obstruction of the diagonal, causing the initial ST elevations. The thrombus then probably embolized downstream, causing the partial resolution of the ST elevations and the subtotal occlusion of the distal diagonal that we now see. So what do we do now? I think it's pretty clear that the LAD and diagonal branch both have to be stented. We're going to have to do some fancy footwork bifurcation PCI after all. So there are a number of different bifurcation PCI techniques, and I've done other videos on a couple of them. For this case, we thought that culotte would be a reasonable strategy since the diagonal turned out to be quite large in diameter. For more details on the culotte technique, you can click on the link here and check out my video on culotte stenting. We're planning to be doing a two-stent true culotte strategy here. That means we'll deploy the side branch stent first. In other words, first stent the LAD into the diagonal and jail the LAD. We'll then rewire the LAD and stent the LAD itself, placing the LAD stent concentrically inside the LAD diagonal stent and gelling the diagonal. We'll then rewire the diagonal and do final kissing angioplasty and pot. So here we go. We're first going to place the side branch stent of the culotte from the LAD into the diagonal. We reloaded the patient with a P2Y12 inhibitor. This time we used prasugrel on the off chance that the patient could also be a clopidogrel non-responder. Both the diagonal and LAD were gingerly wired with a workhorse wire, and thankfully for us, the dissection did not cause much of an issue. We then deployed a 3.5 by 23 millimeter DES from the LAD into the diagonal. Now, the key with culotte is to make sure that each stent is well opposed, especially proximally before rewiring. This reduces the chance that you could end up rewiring underneath the stent strut. So we post-dilated the LAD to diagonal stent with a 4.0 millimeter NC balloon proximally, and remember obviously to withdraw the now trapped LAD wire before inflating your NC balloon. After post-dilating the LAD to diagonal stent, we then rewired the LAD fairly easily with a Pro Water. We then pass a 2.5 millimeter balloon into the LAD to dilate the stent cell. I actually will also often do a kissing angioplasty step here as well. In this case, we use a 3.0 millimeter balloon in the diagonal. This kissing angioplasty step isn't always done, but I find that doing a kiss here reduces diagonal stent deformation from the LAD dilation and will make it easier to rewire and pass equipment into the diagonal after placing the stent in the LAD. This is a little bit similar to the rationale of the first kiss in the DK crush technique. Next, we pass a 4.0 by 28 millimeter in the DES and post-dilated with a 4.0 millimeter NC balloon. Again, make sure that this stent is well dilated before rewiring the diagonal. You want to do as much as you can to avoid rewiring under the stent struts. After post-dilating the LAD, we rewired the diagonal relatively easily with a BMW wire and performed final kissing angioplasty. And here is the result so far after kissing angioplasty. It already looks pretty good, and we decided to do another OCT to confirm. So OCT showed that there was a reasonably good stent apposition in most of the LAD, but a little bit more can be done proximally. as you see here. So POT, or the proximal optimization technique, will be useful. So after POT with a 4.5 millimeter NC balloon, here is the final angiographic result. The LAD looks quite good, and the LAD and diagonal bifurcation looks quite nice as well. But what about the distal diagonal? Well, flow is slightly better, but there is still some residual thrombus over there. We thought that it was a little bit too small to go after, however, so we left it for medical management. These usually clear up quite nicely after an overnight infusion of a 2B3A inhibitor. So the patient ended up doing quite well. His troponin increased minimally to 2 nanograms per mil. There were no wall motion abnormalities on his echo, and his EF remained normal. And he was sent home on aspirin and prasugrel. All right, take-home messages. So this case demonstrates the sometimes quite humbling nature of interventional cardiology. An eminently acceptable angiographic result sometimes still does not tell the whole story. Some edge dissections can be very hard to see. So perhaps the principal take-home message would be to have a lower bar for doing intravascular imaging after PCI. This is especially true for the proximal to mid portions of the main vessels, the left main, the LAD, the circumflex, the RCA. Intravascular imaging is not routinely done for branch vessels like the diagonal, and in this case my sense is that most interventionalists would not have even considered it with the excellent angiographic result after the first PCI. But hindsight being 2020, intravascular imaging probably could have helped avoid a little of the unwanted excitement. Thank you for watching.